All right, let's go ahead and get started. Hi, everybody. What I'm going to do is do a brief 1 to 2 minute conversation about PSS in the webinar, and then I'm going to hand it over to our fantastic presenters. So thank you so much. So the webinar title, the 3D's, Dementia, Delirium and Depression. We've got Dr. Pan and we've got Dr. Patel, who are our presenters. Thank you so much. A little bit about PSS. We were founded in 1962 as an innovative multi-service agency, and we really focus on building the capacity of older New Yorkers. This program is an extension of PSS LifeU University, which provides a variety of online educational courses so that folks can have the information for both themselves and the person or family member that they're caring for. Again, our Circle of Care program provides services for someone who's caring for somebody who is frail, chronically ill, who has memory loss, or a family where a grandparent or family member other than a parent is raising a grandchild. And again, we have a grandparent family apartment building here in the South Bronx that is the first of its kind and exclusively provides housing for kinship families and grandparents raising grandchildren. Our Coming of Age program works to inspire folks over the age of 50 to live with passion and purpose. Our 10 senior centers are helping older adults stay healthy, engaged, and connected, and particularly during the COVID-19 crisis, providing food distribution and resources so that folks know where they can get their next meal. And we always welcome volunteers, even in the digital age. So if anybody is interested in both our services at PSS and volunteering with some of the work we do digitally, please let me know. Please type any questions in the chat box if you have any of them, and we'll respond to them as quickly and as many of them as we can. All right, so without further ado, I'm going to hand over the mic. Thank you so much for y'all's time, and yep, enjoy the presentation.
Thank you so much, Gavin. So my name is Dr. Cynthia Pan. I'm the Division Chief for Geriatrics and Palliative Care at York-Presbyterian Queens. Zoom presentations is a new thing for everybody. So if something goes wrong, just please, I apologize in advance.
My name is Madhuri Patel. I am one of the Palliative Care Fellows here at York-Presbyterian Queens. I just started about a couple of months ago, so very excited to be doing this talk. One of my first talk I'm doing with Dr. Pan, so I'm very excited. And I completed internal medicine residency in Pennsylvania. So I have a background in internal medicine and now training to be a palliative care physician.
Thank you. So we'll get started. Actually, Gavin, I had a question. What does PSS stand for?
PSS stands for Presbyterian Senior Services. So PSS, again, was founded in the early 60s, and we were a group of volunteers who wanted to help and assist the elderly church-going members of our community. And now the full title of our organization is just PSS. We have no specific denominational association.
Okay, great. So we're part of New York Presbyterian, so we have that in common.
Absolutely, yeah.
Yes. So I know we're starting now, but we do have to end promptly at 1:30 because we have other meetings that we have to go to. So I just wanted to give that heads up. Can everybody see this?
I know I'm able to, so
all
yes.
Right. Okay, great. So as you all know, we're going to be talking about the 3Ds of older adults and geriatrics because these are very common and highly prevalent syndromes that we see in the people as they age: dementia, depression, and delirium. Right. And sometimes it's hard to tease them out, so we wanted to kind of talk a little bit about each of them. So I want to start with talking a little bit about the demographics in the US. The number of Americans who are 65 and older is constantly increasing and projected to more than double, from 46 million today to over 98 million by 2060. And actually the most rapidly growing population is the population over 85 years old. The life expectancy at age 65 has increased as well. Back in the 1900s, it was about 12 years. So if you live to the age of 65, you can expect to live an average of 12 more years. And nowadays, it's more like 19 more years. And definitely the older population is growing faster than the younger younger adults population. So these are the figures that you can see. It used to be that older adults back in the 1960s, it was more like a pyramid with the base being younger people, much more numbers wise than older people, whereas nowadays it's kind of equalizing or maybe becoming a little top heavy. So that's not only happening in the United States, it's also happening across the world. As you can see, the purple countries are the ones where the percent of older population age 65 and older is high. And then the next one is the blue, the dark blue, which is many parts of the world, including us. So those are the maps. And we can send that out later to everybody so people can have it. Okay. So why we want to discuss the 3Ds is because as we all live longer, age-related chronic conditions become more prevalent. People tend to accumulate things, a little bit of heart disease, a little bit of kidney disease, a little bit of diabetes, a little bit of high blood pressure, and then things add up. Right. So the rate of dementia and memory changes actually increases with age. So the older we are, the more likely it's going to happen to any of us, and maybe a little bit more among women than men. And also women are the ones who are living longer than men, so that might have something to do with it as well. But basically, if someone is in their 80s, the chance that they have some sort of memory impairment could be as high as about 20-something%. And by the time somebody's in their 90s, it could be up in the 25 to 30s range, or maybe even higher. The rates of depression exists across all ages, including elderly people. Some people might think that, well, you know, depression mainly happens in younger adults or maybe like people in middle age, but definitely people who are older are not exempt. And delirium can also happen. I mean, depression also has a higher rate among people who have dementia. So these things can happen simultaneously as well. And then delirium is definitely not a younger people's problem, it's an older people's problem, mainly because of the risk factors that we'll go into a little bit later. So we're gonna start with a case of Mr. D, who's a 72-year-old man who was brought in to see his doctor by his daughter because of progressive memory loss. He says that he doesn't have any problems. He previously worked as an accountant. He's now unable to balance his checkbook. He has been getting lost while driving to the store, and he was also diagnosed with depression a couple of years ago after his wife died. In addition, he has high blood pressure and diabetes, and his blood pressure is a little bit on the high side in his doctor's office. So just listening to this, what diagnosis would you think best fits his situation? Okay. So we're thinking, you know, depression is definitely a possibility, but definitely more likely dementia. In terms of depression, he had it a couple of years ago, so he definitely is at risk for it. But also it was in the circumstance where his wife died, so it could have been like an acute grief reaction. Sometimes people have difficulty teasing it out. But if he's clearly having memory loss, then we have to think about dementia. Especially he used to be an accountant, so he should be very good with numbers, and now he can't balance his checkbook. That's a big concern and change from his baseline.
So getting right into what dementia actually is, it's actually a collective term. I think a lot of people, there's a misunderstanding, assuming that dementia is one disease or one diagnosis, but it actually is an umbrella term for a number of different types of dementia, which we will touch on in a moment. But it's a collective term used for a group of disorders that's characterized by a decline in memory in at least 2 cognitive functions that actually affect someone's daily life, which again will kind of differentiate what that means to affect your daily life. It is progressive, and it does impair the ability of an individual to carry out routine functions. Onset is generally very slow. Again, it's progressive over over a number of years. Onset is important to note just because it does help us differentiate between the different Ds, which we'll be able to summarize at the end. Oh, prevalence. Okay. Just touching on the prevalence of dementia, we know it's very common. I'm sure you guys know, know somebody with dementia, but it does affect more than 5 million Americans. 5% of people aged 71 to 79 are affected by dementia. The percentage increases as the age increases. We do see it up to 37%, sometimes higher in patients that are aged over 90. Alzheimer's dementia, which I do want to touch a little bit more on relative to the other types of dementia, is the most common. And because it's the most common, most diagnosed, I do want to touch on it just a little bit more. Coming back to mild cognitive impairment versus actually dementia, like we mentioned, dementia is progressive and it affects daily functioning. Mild cognitive impairment, on the other hand, is some disturbance in cognition, but without impairment of daily functioning. Basically, you can consider it a progression. So you usually start with a mild cognitive impairment, which doesn't necessarily affect your daily functioning, just forgetting things here and there, which may or may not progress to higher levels or higher stages of dementia. Wanted to oh no, sorry. Okay, so just to briefly touch on the different types of dementia, like we mentioned, dementia is an umbrella term. It's not just one thing. There are different, different types. Alzheimer's being the most common. 62% of the people diagnosed with dementia are usually diagnosed with Alzheimer's dementia. Most common symptoms we see with Alzheimer's are trouble with memory, language, reasoning, like balancing a checkbook, things like that, like things you were previously able to do. Vascular dementia seen in about 17% of cases. Again, impaired judgment, this time more difficulty with motor aspects and balance. More associated with medical diagnoses like heart disease and strokes, and especially elevated blood pressure. Mixed dementia is where we're not able to really categorize from one type to another, seen in about 10% of patients. More common in elderly populations above 85. Dementia with Lewy bodies. Lewy body is a specific protein that deposits in the brain. This type of dementia is more commonly associated with hallucinations. It's kind of a hallmark sign of Lewy body dementia, keeping in mind that hallucinations can be associated with a number of other diagnoses, not just Lewy body dementia. Frontotemporal dementia, 2%, not as common, but hallmark feature of this type of dementia is a change in personality, a stark change in personality, not just a subtle change. Somebody who's usually very pleasant, very nice, a people person, all of a sudden you start noticing that they don't like talking to people, they're very angry. And then we have Parkinson's disease. Keeping in mind, Parkinson's disease is not primarily characterized by dementia. It's more of a motor disease, but 2% of patients with Parkinson's can develop memory dysfunction. And then we have other. There's 3% that's categorized. There's a number of other conditions and diseases that may be associated with cognitive decline. So like I said, we want to touch just a little bit more on Alzheimer's because it's the most prevalent. 65% of patients that are diagnosed with dementia are diagnosed with Alzheimer's specifically. More than 5 million Americans are living with Alzheimer's, and we're expecting by 2050 that number to increase to almost 16 million, which is considerable increase. We wanted to highlight, we put this in red, that 35% of caregivers for people with Alzheimer's or another type of dementia report their health has gotten worse because of care responsibilities. I think it's an often underlooked aspect of Alzheimer's disease. We always worry about the patient and management of the patient, but it's so important to also highlight the caregivers and how much time and effort that they're giving to their loved ones. Alzheimer's disease, it kills more than breast cancer and prostate cancer patients combined, and it is now the 6th leading cause of death in the United States. Just to touch on healthcare costs of dementia as a whole, we are seeing up to like $226 billion of healthcare money going towards dementia care per year. And by 2050, because of the surge in the elderly population that we're expected to see, the costs can rise as high as 1.1 trillion. And makes sense when we say that dementia costs actually exceed the total cost of care that's going into cancer and heart failure combined. So pretty significant numbers. So big question, why does dementia occur? There are a number of dementia types that we went over. So each type of dementia has its own physiology, its own reasoning behind it. Alzheimer's dementia specifically, because it is the most common, it does have the most research put into it. And thus far, the working diagnosis that we have is that we're seeing a deposition of what you can see here. They're called amyloid plaques. These are abnormal collections of proteins or just material that's being deposited into the brain. And that's what's causing the symptoms that we're seeing as Alzheimer's. Now, when we look at an Alzheimer's brain versus a normal brain, you can see that there is a significant amount of mass and just loss of volume compared to a normal brain, again, contributing to the symptoms that we're seeing. Risk factors associated with dementia. Of course, we all know age is probably the #1 risk factor. We do see an increased risk as we progress in age. That number can be close to 50% for patients that are over 85 years old. A family history of Alzheimer's can play a role. It doesn't necessarily mean that you will develop Alzheimer's, but there is a small connection there. Traumatic brain injury, depression can contribute to dementia. Physical inactivity, we have seen studies that show activity has a positive effect on memory and functioning. And then you have your chronic diseases like diabetes, high blood pressure, strokes, heart disease, things like that pose a risk as well. So I wanted to note a difference between mild cognitive impairment versus dementia. We mentioned mild cognitive impairment, it's kind of normal lapses in memory and little things, but they really don't affect your daily functioning. And that's what really differentiates normal lapses versus dementia. So normal, you can forget a name sometimes, you can leave a kettle on the stove maybe once, you have difficulty finding the right word for something. You forget today's date or day, which I think happens to almost everyone at some point. Dementia, on the other hand, instead of just forgetting the name, you're not able to recognize a family member, somebody that has been in and out of your life for years. When you start noticing real personality changes, that can be indicative of different types of dementia. Getting lost in your own neighborhood, things that you've been doing day in, day out for years at a time. Our case that we talked about earlier, Mr. D, he was an accountant, and now, over time, he's now unable to work with numbers. So it's a very unusual and unexpected change. Normal lapses, trouble remembering a number, you're losing your keys, misplaced them, feeling sad about certain situations, the loss of a loved one. It's expected and normal to feel sad and have a period of grief. On the other hand, when you have sudden personality changes, it's not really consistent with what's going on in their life, rapid mood swings, or not, we already mentioned not recognizing numbers. So screening test. This is always a big question and always a big concern. I don't want to get into the, the nitty-gritty of this screening test. There are a variety of tests, or variety of cognitive functioning tests that your primary physician can offer. On top of that, some simple blood tests just to rule out any underlying nutritional deficiencies, thyroid abnormalities, things like that. But it really is kind of a diagnosis of exclusion. We want to make sure that there's nothing else that could be contributing to this person's cognitive dysfunction. And with a combination of blood tests and some of these written tests, I think you can make a pretty good diagnosis of cognitive impairment or dementia. So important to note, 3 stages of dementia. I wanted to mention this early, middle, and late because I think knowing the different qualities or characteristics of each stage can help you guys as caregivers and family members and, identify where a loved one is and really help you prepare for the future and what to expect. So just briefly touching on the 3 stages. Early stage, we see that, somebody might start having difficulty managing their finances. It's got a kind of a complex, I guess, problem or something that they have to work through. Forgetting recent events and names, not remembering to take their medications, or not remembering people that used to be very familiar to them. Middle stages, now we see that they need more help with complex chores and hobbies. They're getting lost in familiar places. They have periods of agitation. Their mental status is not always, they kind of wax and wane. You'll notice. They have good days or they'll have bad days. And then recognizing family members again. And then the 3rd stage, this is where we do tend to see a pretty rapid decline in a person's functional status. You'll start to notice that they're having difficulty swallowing or eating. They're not able to walk or do simple activities of daily living like bathing themselves, feeding themselves, dressing. Their communication skills really start to deteriorate. And we do unfortunately see a recurrence of infections. Oftentimes, patients with late stages of dementia, Alzheimer's, tend to be in and out of the hospital a lot. Now, before we really get to management of dementia as a person or a patient, I really want to highlight how important it is to identify and take care of yourselves as caregivers. I can't stress it enough. I think you guys know better than I do, but being a caregiver is a huge responsibility. Like this graphic we have says, 65 million adults in the US care for a loved one. And the number of hours that these caregivers are spending, caring for their loved one, helping them bathe, helping them eat, it's just over 20 hours a week. I mean, it's honestly another full-time job. And with all of that in mind, it's so important to avoid burnout as a caregiver. Just make sure you're taking care of yourself. You are doing things that you enjoy as a caregiver outside of the home, outside of that responsibility, outside of that job. Get enough sleep, have balance, exercise, whatever is important to you. And important also finding that support group, whether it's with your family members, your friends, or even reaching out to professional support groups, which I have some information later in the slides with some organizations that do offer support groups for caregivers. So moving on to management of dementia as a patient. There are medications, however, very conflicting evidence with the medications. There is no medication that truly stops progression of dementia or reverses signs of dementia. The medications we have, they're generally best implemented during an early stage of dementia, and they are said to help slow down a progression. And again, conflicting evidence when it comes to that. The most important thing, and I think the most beneficial things we can do for patients with dementia is things like stimulation, cognitive stimulation, doing activities like card games and paper pencil exercises, increasing physical activity. That's definitely been proven that higher levels of physical activity really helps stimulate the brain. the feeding difficulties at the bottom, we wanted to put that in there, I think, towards the later stages of dementia, because your loved one or the patient is having more difficulty eating or maintaining an appetite or feeding themselves. The thought of nutrition comes into mind. Oftentimes, a lot of times, the option of putting a feeding tube is offered. However, based on the evidence that we have and the studies that have been done on a number of patients with progressive stage dementia, there really is no benefit. It doesn't really help prolong the time patient has. If anything, we feel like that it is associated with a lot more complications, like infections, hospitalizations, things along those lines. So here, just I wanted to, again, we'll send the slides to you, so you'll have all of these links. But I was on the Alzheimer's Association website. They have a specific New York City chapter, which I think they have some really great resources. They have a 24/7 helpline. They have over 200 languages that they have available to speak with caregivers and patients and themselves. But they also have different associations. There's a 24-hour assistance to help with a patient, getting them bracelets and necklaces and clothing tags, things like that, in case, God forbid, they get lost. There are resources for driving, as the disease progresses. I think that's a big concern and something that, maybe you want to have a road test done to see how safe it is for your loved one to be driving, things of that sort. Also support groups. Alzheimer's Association of New York does have support groups as well.
I just want to add that for New York, Alzheimer's Association is a national organization based, I believe, in Chicago, and each city, major cities have their chapters, so New York has one. In addition, for New York City, there's also another organization for dementia patients and their caregivers, and it's called Caring Kind. So that's easily, you can find it easily on Google, and they have a lot of services as well. So between Alzheimer's Association and Caring Kind, definitely, reach out for help if you need some. Yeah. Okay. So now we're gonna switch gears to another case. Misty is a 75-year-old woman living alone in her apartment in New York. Her husband died suddenly 2 years ago of a heart attack. They have 2 children who are alive and living out of state, so farther away. Both her sons may, call her on a weekly basis and visit once a year. Misty has been doing well until about 6 weeks ago when she fell in her apartment and she had bruises but didn't have to go to the hospital. Since then, she's been preoccupied with her failing eyesight, her decreased ability to walk, and fearful of walking and falling. She doesn't really go shopping as often. She doesn't really enjoy going out anymore, and she feels very sad and teary. So what is the diagnosis that we're looking at? So in this case, she has a lot of symptoms that would be concerning for depression, right? And what is depression? It's basically an affective disorder, meaning a disorder that affects our emotions and psychological well-being. It's shown up by a mood that's a sad, dysphoric mood. But actually the most pervasive symptom is a loss of ability to enjoy usual activities. So that's an important question to ask, from a doctor's perspective. What do you usually like to do, and have you stopped doing things that you usually like to do? About 17 to 37% of older adults with medical problems do experience depression. Depression is very common in people who have dementia, like I said before, but also in people who have had a stroke, or in people who have Parkinson's disease, people who have heart disease, and people who have certain types of cancer, most notably pancreatic cancer. Major depressive disorders are seen less often in older adults compared to younger adults, but it can be very insidious, maybe harder to diagnose because people kind of just retreat, and it can happen over a longer period of time, so people may not notice it as much. Older people, when they get depression, they tend to get more delusions or kind of psychotic symptoms, more so than younger people. And the risk of suicide is also higher in older adults than the rate for younger people. So it's definitely a big public health problem that we are very mindful of and want to educate everybody about. So once you learn about the 3Ds, dementia, depression, and delirium, we would hope that you talk it up with your friends and families and raise awareness in the community as well. So the symptoms of depression include, like I said, loss of interest or pleasure in activities, especially things that they used to enjoy, kind of expressing feeling slowed down or restless, feelings of worthlessness or feeling guilty, like, oh, you know, I'm getting older and I don't feel like I'm worth anything to anybody anymore. I have nothing to contribute, things like that. Feeling constantly tired, having trouble sleeping or sleeping too much, one, you know, either end, having recurrent thoughts of death, or even more alarming, having thoughts of suicide or self-harm, becoming more agitated or irritable compared to their usual, and having hallucinations, whether it's seeing things or hearing things that are really not there. So these can be all some sort of presenting signs and symptoms for depression. So when someone who's older goes to their doctor with symptoms like that, oftentimes their doctors might do a geriatrics depression scale, which is a screening of multiple questions. But it's important to know that if somebody is having dementia or delirium, either one, that the geriatrics depression scale is not necessarily completely accurate. So this is a picture of the Geriatrics Depression Scale, which has 15 questions. And they involve things like, are you basically satisfied with your life? Yes or no. So once you tick off, if there are 5 or more questions that are kind of red flag questions, then that's an indication to kind of go on more with the diagnostic pathway. So have you dropped many of your activities and your interests? Do you feel like your life is empty? Do you often get bored? So you can see these are some of the types of questions. In terms of interventions or treatments, definitely we have many more medications nowadays compared to 20, 30 years ago. We have a lot more options, and we have antidepressant medications that are not only effective, but they also have lower risks and side effects profile. So I would say that it's a good time to get depression treated. A lot of people may be afraid to mention that they have symptoms of depression, or might be afraid to go on medications because of the stigma. But I would say that, you know, life is short and we want this life to be the best life possible. So if there's something that's treatable, we shouldn't really, you know, think of it as a stigma. We should be brave enough and just be, you know, very open-minded about getting treatment and support, because once depression is treated, people can feel a lot better and have a much better quality of life. Medication is not the only option. There's also psychotherapy, group counseling, individual therapy, as well as community and group support groups that can be very, very helpful.
Okay. Thanks. So our final case, we have Mr. A. Mr. A is an 81-year-old male diagnosed with Alzheimer's. He lives in a care home. He's usually very friendly, talkative, willing to participate in group activities. He is often disoriented, not necessarily aware of the year, date, month, things like that. But very pleasant. In the last couple of days, Mr. A has been shouting through the night. He's been only sleeping 3 to 4 hours. He's now incontinent of urine, which is unusual for him, and accusing the nursing staff of trying to poison him. So just very kind of erratic, unusual. The diagnosis that best fits, we would say delirium. Going right into delirium. So what is delirium? It's a serious disturbance in mental abilities that results in confused thinking, reduced awareness of the environment. It's usually very rapid, important to note, because this kind of helps differentiate between the 2 other Ds. Usually we see this onset within a number of hours or a couple of days. More often than not, we can trace delirium back to certain contributing factors. like severe medical illness when somebody's admitted to the hospital for a serious illness, changes in your metabolic states, changes, like low sodium, thyroid, things like that. Changes in medication, I think that's an important one to highlight. Infection, surgeries, really just kind of anything dramatic that can happen from a day-to-day being. We did want to, are we okay with time?
Mm-hmm.
Okay.
Yes.
I'm just going to play this video. It's quick. It's maybe 2 minutes, and I think a good representation of how we see delirium oftentimes in the hospital.
Hi there. It looks like the video itself is having a little bit of issues.
Oh no. Okay, that's okay. It's so we don't. It was almost done. Bin the video. I don't know how much you guys were able to see. Thank you for that. But this gentleman, he's in the hospital. He's seeing things. The nurse who herself had delirium when she was once hospitalized mentioned she felt like she had to get a hammer and get the birds out of the wall. So just very unusual changes, very rapid and sudden. Risk factors for delirium. So some modifiable, some not so modifiable. Advanced aged or very, very young age, like the video mentioned. Gender sometimes, living single at home. So this is just because there's not necessarily a familiar face that they can orient themselves with. Predisposing diseases like heart disease, already predisposing a history of dementia or depression, lung disease. Really, a large number of diseases can be predisposing factors that can contribute to the delirium. Things that are a little bit more modifiable is a change in environment. So all of a sudden when somebody wakes up in the middle of the night and they're in the hospital and they don't realize, we see oftentimes that they're delirious. They have a hard time grasping their surroundings and bearing ground as to where they are. Isolation is a risk factor associated with delirium. Physical restraints, we always try to do our best to avoid restraints at almost all costs because they do contribute to confusion and agitation. Unfortunately, the longer somebody stays in the hospital, the more critically ill they are, the higher risk they are of becoming confused. Management of delirium, it's easier said than done. There is no FDA-approved medication for delirium. The best thing that we can do for managing patients with delirium is all non-pharmacological, so no medications. It's all keeping familiar routines, keeping familiar faces. So when families come to visit and they reorient their loved one, it really makes a difference. Avoiding sleep disruption, maintaining a wake and sleep cycle. So when it's daytime, try to keep sunlight, try to keep them next to a window, and having them aware that it's daytime and nighttime is bedtime. Encouraging mobility, trying to get patients out of hospital beds or at home. Just encouraging physical activity is always a great thing. We mentioned avoiding restraints, frequent reorientation, and then I mentioned the sleep and wake cycle.
I just want to add also that during the COVID pandemic, it was very difficult, especially for a lot of our older patients, because they had risk factors for delirium. Now they're in the hospital, they were acutely ill. Maybe they had COVID, which can also affect their mental status and neurological condition. And now the hospital does not allow any visitors to come in because of COVID risk. And so now these patients were not able to see familiar faces anymore. It was really a lot of suffering for many of our older adults going into delirium, and we really had trouble implementing some of these things. So, prevention is always a good thing, and that's why from the hospital side, as soon as the patients were stabilized, we wanted to send the patients home so that they could be home with people that they were familiar with.
Tying right into that, I always like to put this in there. It's a little comment. Try to get some rest. I'll be in every few minutes to make sure you don't. Just to highlight the fact that we try to get our patients out of the hospital back home as soon as we can, because unfortunately, as much as we want our patients to rest, we also check in on them very frequently. To kind of close things out, almost some outcomes of delirium. Unfortunately, we do see a high rate of mortality for patients that experience delirium in the hospital. When they are delirious, it does tend to increase the length of stay in the hospital. Risk of complications increases, like falls or increased infections. There is a link between delirium and dementia, and it goes both ways. And the risk of becoming admitted to a nursing facility also increases. Just to summarize the 3Ds, I think we highlighted onset is a good differentiating kind of factor that we can use. Depression varies, it can be somewhat rapid or it can be progressive. Dementia, we did mention that it's much slower. It usually develops over a period of years, whereas delirium, it's the most abrupt. It's the quickest rapid onset, hours to days. Symptoms, depression, it's more of a mood disorder. You get a feeling of sadness, loss of pleasure in doing things you once enjoyed. Symptoms of dementia are characterized by a decline in functioning. So things that you were previously able to do, like balancing your checkbook or recognizing faces. And delirium, it's more of it's a change in consciousness. So you're really just not aware of your surroundings, which really disturbs their mentation. Depression, I think, as we may know, it can be episodic. It is definitely treatable, which is why we want to identify it early. Dementia, it is progressive. It's manageable, but not necessarily treatable, I guess. Delirium, on the other hand, is treatable, but also associated with a number of consequences like we just discussed.
Yeah, I just wanted to add on to that is that sometimes, we have a patient in front of us and it's truly not that easy to tease it out, especially if there are coexisting conditions. And I think that the way I approach it is that somebody who has dementia will preserve their social graces in that they will be very eager to speak with you, but keep it very vague. So I might say, oh, Mrs. Smith, can you tell me where you are? If they're in the hospital, let's say. And then Mrs. Smith might say, well, I'm here where I am. And I'm like, well, tell me the name of this place. And then I might say, well, don't you know the name of this place? You tell me where you are. Basically, just not answering the question specifically, but trying very hard to hide it. And then somebody with delirium would not even be able to keep up with that conversation. You might say, oh, Mrs. Smith, where are you today? And I might say, oh, what's that over there? Or maybe the public announcement came on and they say, oh, who's speaking? They really just can't stay with the conversation. And then somebody who's depressed will not really care. They just devil may care attitude. You might say, oh, where are you today? And they just like look down and not even really ask, or say, well, does it really matter? So that kind of differentiation.
Yeah, that's great. Just some more information. You'll have access to a lot of these links. I think we talked about some of the resources that are available for the community, and same. And then some geriatric specialists that are affiliated with our hospital. Dr. Pan is geriatric trained, but for inpatient consultant patients, and then a couple of other physicians in the surrounding area that are also trained and specialize in geriatric medicine.
So if you have anyone that you know who has geriatric syndromes where there is dementia and memory impairment, or depression in someone who's older, or maybe delirium just coming out of the hospital but not really resolving, or something else like falls, you can make a referral to those physicians.
And that's it. I think we had some questions that I saw pop up.
Absolutely.
So stop sharing.
Oh, okay. Volunteering, absolutely. Oh,
Oops. Okay.
Oh, that's
the chat. Okay.
Oh, that's a digital support group. Okay.
So we'll definitely send a copy of the talk out.
Yes, definitely.
There's a question about depression or vascular dementia.
Sure.
Oh, the video is not running.
Oh.
Sorry. There's a question about what about patients' Alzheimer's?
Can you elaborate a little bit?
Yes.
Yeah.
So for patients who have Alzheimer's, you can also refer them to any one of the geriatric specialists. A lot of primary care physicians also have the ability to screen for dementia and provide treatments and do referrals. If you feel like the primary care physician may not be as well versed, you can always request a geriatrics consultation. Any other questions? I do accept United Health, and like Dr. Patel was saying, because of my other responsibilities, I'm pretty much limited to working inside the hospital. So I really only end up seeing patients who are admitted to the hospital, not on the outpatient basis. And yes, we'll send the presentation to Gavin, and he can send it out to everybody. What actually causes death in people with dementia? Yeah, that's a very good question. So the actual is probably a lot of times infections. People who have end-stage dementia are at a very high risk for infections, including urinary tract infections, aspiration pneumonia, or other types of bacterial pneumonia. Or sometimes if they become completely not mobile and develop pressure ulcers on their skin, they can develop infections from the skin. So the most common pathway is actually infections. Another question, we work with a client who has mild to moderate dementia, help families and resources. Families often want counseling for the family member, but we have to explain that the person cannot remember conversation to conversation and it's not appropriate for counseling. Yeah. So when it comes to counseling, so that's why we were talking about how when we take care of patients who have dementia, it's 50-50. It's 50% of the care towards the person who has dementia and 50% for the caregiver. Because the person who has dementia, there's no cure, there's no reversing, and we do the best that we can do with medications and reinforcing memory games and exercises But the other part is, as people develop dementia, they require more and more help from the caregivers, and it's a very stressful job. And we have to make sure that the caregiver gets the support and the education to know how to manage dementia patients. It is true that with patients who have dementia, if you counsel them something they're not going to remember, maybe even 5 minutes later they will not remember. So maybe it's good to write it down. I definitely recommend that all patients with dementia carry a beautiful notebook where they can write things down so that they can refer back to it later. That's a very good gift to maybe give to dementia patients and the caregivers. I would say also I've met quite a few caregivers who get frustrated when the person who has dementia doesn't remember what they just told them 5 minutes ago and keep asking repeated questions, or become irritable, and it really frustrates the caregiver. And the caregiver really needs to realize that the dementia patient is not trying to do that intentionally. They really can't help it. So if they're refusing to do an activity, they don't want to go someplace, they don't want to eat, just leave it. Just let it go. It'll be a lot less stressful for the caregiver. Just let it go and say, oh, okay, you don't want to do that now? All right, we'll come back to it later. If you go back 10 minutes later, they may have already forgotten that they didn't want to do that before. So take advantage of it, okay? But learn to let go. The other thing with dementia is that it's a progressive loss of the ability, verbal ability, and there's more and more evidence to show that maybe music therapy, which affects the other part of the brain, may be a good way to get through to dementia patients. So instead of trying to verbally talk to them and say, come down, don't do this, maybe try to select music that they like from whatever period of time that they can identify with, or just ask them and play music, and that could be very calming sometimes. Good advice for caregivers, thanks. Can use music from the favorite era stimulate? Yes, definitely use music from the favorite era, stimulates the brain. There was once, I can't remember the name of the film, but it was basically a social worker and music therapist who did a study in a nursing home working with dementia patients using music, and basically put on headphones or whatever and play the music that they prefer. They got the information from their loved ones, and the patients who were originally like quiet, mute, withdrawn, really came to life and responded and were tapping their feet to the music. And one dementia patient even actually started dancing to the music, and it was beautiful. Send the list of doctors to, okay. F91 severely, okay.
We'll
So
them.
Gavin, if we send the PowerPoint to you, you'd be able to get all this information out, right?
Absolutely.
Okay. Any more other things on the chat that we didn't get to address? Oh, wait, I see something on a Q&A. Okay. Family weekly calls and a visiting a family member once a year, is that sufficient? Okay. Probably not, but you know, each family is different and they can only do what they can do. So sometimes family members who are away, they may choose to hire like a geriatrics care manager to help them who's closer. And also don't forget to ask for help. Even if the immediate family is not here locally, there might be other family members that are around. Nieces, nephews, grandchildren, you know, this is not the time to be shy, just ask for help. And the other thing to remember is that different people have different strengths. So call on people's strengths, maybe call a family meeting and say, hey, we need help right now to take care of grandma. Who's good with money and finances? Who's good with arranging aids? Who's good with visiting? Who's good with getting food? Don't have one person try to do it all and it's not their strength. But when you get a group of people together, many times they'll say, oh, I'm good with this and I can do that. And it's only one piece of it. Another question about, we work with a client, has mild to moderate dementia, help families. Oh, okay, so that's already, we did that. Mother has frequent UTI, could that cause dementia, depression, delirium? So it's usually that patients who have dementia are more prone to UTIs, but if this person has frequent UTIs and already has some memory impairment, then that can put them more at risk for delirium, having an acute infection. I hope that's clear. So somebody who already has memory problems or multiple medical problems, once they, or maybe they don't hear as well, they don't see as well, if they end up in a hospital, they're at much higher risk for delirium. So you want to make sure you visit or call, make sure that you keep their routine as much as possible, and get them, get them up and moving if they're able to walk when they're at home, and really try to, as soon as they're stabilized, to get them out of the hospital. Those are all the questions that I see. What time is it? So I think our time is up. We want to say thank you, and thank you for all your wonderful questions.
I hope this was helpful
Thank
information.
you very much to both of you.
Great. And we also can speak in the future with this group about other topics, including falls prevention, advanced directives, which is very important. So feel free to reach out through Christina. Oh, I see another couple. I think, oh, wonderful.
Oh,
thank
thank
you.
you.
Thank you so much for the wonderful feedback.
Yeah.
All right, well, this wraps us up. Again, thank you so much to our wonderful presenters, and I will be sending out all of the appropriate follow-up information to connect folks with
Great.
what we talked about.
Gavin, also for us, if you can save a copy of the chat and send it to us, that would be very helpful.
Sound.
Thank you so much. Have a great
Have a good
day.
day.